the main event. Delighted to welcome Professor Rebecca Fitzgerald. She's a professor in the University of Cambridge, of course, fellow Trinity College, and doing pioneering work on the early detection of cancer, a very serious and important business. Rebecca, please.
Well, thank you, everyone, in this wonderfully cold lecture theatre to keep us all awake and at home. It's a real pleasure. The only thing I wondered about your annual general meeting was about the appointment of the independent examiner, which sounded a little bit worrying to me, but I presume that's nothing to do with examining the talk. So, very nice to be here. So, these are my disclosures. We have licensed the technology I'm going to talk to you about, Cytosponge and related assays, to Covidian, now Medtronic, and I'm a founder and shareholder of Cyted. So let me start by just giving you a broad kind of introduction to why early diagnosis of cancer is so important. And I guess in a way it's probably self-evident to you, but if we can detect cancer at an early stage, that allows the best chance for cure. Not only improving survival, but improving, importantly, the quality of life. Because often if the cancer is very localized, it's very straightforward to treat it, and you may not need systemic chemotherapy. So not just about prolonging survival. So we're familiar with screening programs that we have in the NHS and internationally, and the screening programs that we currently have in the UK are for breast, cervix, and colon. But there's been a lot of discussion about the benefits of screening, but also the harms that can be caused and how we might improve things. And there's been an independent review of adult screening programs in England, and a recommendation from Mike Richards' report and the UK National Screening Committee that we should think better about how we can do more targeted screening, by which I mean not one size fits all. Think about who is at most risk of particular forms of cancer and then test them accordingly. And also within a screening program, to adapt that screening program according to someone's risk once they're in the program. And the screening that we have is not sufficient to really improve the outcome that we're seeking from cancer. And so the NHS long-term plan has set this very ambitious target that we should improve the diagnoses of cancer at an early stage when they're more curable, from around 50% currently to 75%. That's really quite a tall order. That's aimed by 2028. And so one of the big questions is how we really achieve that effectively. So let's just step a bit back a moment and just say, you know, why is it the case that you can really detect cancer early, and actually how early is early? Because actually cancer evolves very gradually over a period of years. It's effectively a Darwinian process of competition of the cells in a tissue, and those with the fitness advantage will be the ones that survive. And in our normal tissues, as we study increasingly normal tissues as well as cancer, it's clear that our cells carry within them many mutations, and those mutations increase as we age, but happily, most of them will never cause us any problem. But within the tissues, as those mutations occur, they can then confer an advantage, and you may get small lumps arising. The cells can start to become disorganized, which we might term dysplasia, until they start to develop a very localized early cancer. Now, this is the basement membrane here, and as long as the cells stay above that and don't start going deep into the tissues and invading nearby structures or into the blood vessels and lymphatic drainage, then you're not really going to experience much at all in the way of symptoms. And so these may not be clinically evident. It's only really when you start to get locally invasive disease and then, of course, metastatic spread that you'll have symptoms evolving. So as our technologies become more and more sensitive to detect these cancers early, we'll start detecting these things, in which we can intervene early, but we may also potentially start detecting things just from normal aging. So that's one of the challenges about how we start to distinguish between indolent things, which really are inconsequential, and potentially lethal changes, which really we need to do something about. So there's been a lot of discussion about whether cancer is really inevitable as we live longer and longer, that we'll all get cancer. And in fact, about 1 in 2 of us will get cancer in our lifetime. And if we can compare normal young tissue to aging healthy tissue, we start to find cells with mutations dividing, colonizing the tissue. And some of these mutations, when we look at them, are genes that we recognize in cancer as well. But they will not necessarily cause us cancer. So there's been some fascinating work studying this in aging eyelids. Turns out to be a very useful tissue to study this in, because you can easily resect the eyelid. And aging farmers in Norfolk who have a lot of sun exposure, their eyelids get rather droopy. And so they have them removed, blepharoplasty. And then Phil Jones and colleagues have studied the mutations in that removed skin and shown that you really find a surprising number of mutations in bona fide cancer-causing genes. But cancer of the eyelid is pretty unusual. We really don't see it. So one of the important things for us to really understand in cancer biology is, what is it that turns aging healthy tissue into a cancerous tissue? Is it just to do with which gene happens to be mutated? What causes that? And how might we then prevent it and even reverse it? So the esophagus is what I'm going to focus on. And the esophagus is a very convenient tissue to study because the esophagus is quite accessible. But also we know quite a lot about the stages of cancer. So this is an endoscopic view looking down towards the stomach. And the normal squamous esophagus is squamous epithelium, rather like the skin. And the main risk factor for this type of esophageal cancer, called oesophageal adenocarcinoma, is chronic exposure to acid and bile reflux. So the sort of thing that makes you feel heartburn. And you can see here, I hope, that this lower part of the esophagus has turned a deep velvety red color. And that is the precancerous Barrett's esophagus. And that, in a small proportion of people, may progress to dysplasia and to cancer. And the pictures underneath are sections through the tissue, just to show you the structure under ordinary light microscopy. So this is the normal squamous epithelium. This is the Barrett's esophagus tissue, the precancerous tissue. It's a very dramatic change, as you can see, in the tissue architecture. So actually, if a pathologist was to look at a piece of this tissue, a biopsy, without knowing that it had been taken from the esophagus, they may well think they were looking at a sort of slightly abnormal piece of stomach tissue or an intestinal tissue, and actually it bears the hallmarks of the cell types we find in the esophagus. This particular one I've chosen as an example, which you don't often find, but here, this little gland here is a submucosal esophageal gland duct. So that would be a telltale sign that this has truly come from the esophagus. But you often don't find those. Now, the other point to make is that the majority of people with Barrett's will not get cancer. So this shows you the progression rates. So from Barrett's with no dysplasia, so it's not a worrying type of Barrett's, there's no histopathological abnormality of the cells, other than just being this different architecture. The risk of that getting to cancer is pretty low at about 0.3% per year. But as soon as we find dysplasia, then the risks increase substantially, to the extent we now intervene at this stage. So the reason that esophageal cancer is a very relevant tissue to talk about, relevant cancer type to talk about when we're interested in early detection, is that the treatments vary substantially depending on the stage of disease. So if we detect the cancer when it's in situ or dysplasia, we can actually treat this as an outpatient day case down the endoscope. So we could do microsurgery down the endoscope. We can burn off or ablate the lining with a catheter like this. This is a radiofrequency ablation catheter with excellent survival rates. Most of our patients present with advanced cancer. So 60% of patients that we see in our weekly meetings have got advanced cancer or metastatic disease. And if it's advanced cancer, we're talking about 3 to 6 months of treatment with chemotherapy and surgery, and often, even then, the survival is rather poor. So let me just digress for a moment and tell you a little bit about Barrett, after whom this condition is named. So Norman Barrett was a surgeon who described this condition in the 50s. It turns out he was actually a student at Trinity College, where I'm a fellow. And he thought it was, at first, with his colleague Alison here, he thought it was a congenital abnormality of the esophagus, that it was congenitally short, and that the stomach was sort of pulled up into the chest. And it later became clear that it's acquired, not congenital, occurs in adulthood following chronic damage, as I said, by reflux, that causes this fundamental change in the tissue architecture, a sort of switch in the cell phenotype. I thought I could perhaps see if I found out any information about Norman Barrett in the library, and I went and had a look in the Wren library, and I did find a note about his obituary, but the comment wasn't quite what I was expecting, because it described him as having a guileless and caustic tongue, which isn't normally what you expect to find in an obituary. But there you are. He still has his name attached to the condition. So I don't want to dwell on this in a lot of detail, but I thought it would just perhaps be interesting as to some of the kind of fundamental research going on in this condition before I get on to the diagnostic that we've been developing. Because the question arises, where does this tissue come from? Because it's such a fundamentally different tissue from the normal stratified squamous epithelium. What causes this switch? And there have been a number of different theories and a lot of controversy in the field about exactly how this happens. So one theory is that it's a transdifferentiation, which means it's a change from one type of mature tissue to another type of mature tissue without requiring differentiation, without requiring cell division. An alternative theory is that it's a reprogramming of the gastric cells. So this is occurring right at the junction between the esophagus and the stomach, and maybe the cells right at the junction are reprogrammed to form the Barrett's esophagus, including these intestinal hallmarks. An alternative theory is that there have been some evidence for residual embryonic cells residing at this location, and maybe they then expand and develop this new metaplastic area of Barrett's. All these submucosal glands, and I pointed one out to you in this picture here earlier, they're glandular, sitting deep underneath this squamous structure. Maybe they actually regenerate and expand to cause the Barrett's. So 4 different theories. And it's been really difficult to tell which theory is correct, because there aren't good animal models for this condition. And the curious thing is it must develop really quite quickly, because we never see it evolving. So in a patient, when we endoscope a patient, they either have Barrett's esophagus or they don't. We don't obviously endoscope people very regularly. But presumably, when it develops over a period of days or weeks. And the length at which it develops is quite variable. It can be 1 centimetre or even up to 15 centimetres of this Barrett's esophagus in the most extreme case. And it always stays the same length. And it even stays a very similar shape. So just as I can recognize a person's face, often when you're endoscoping the same patient to monitor their condition, you can recognize their Barrett segment having the same form and the same shape. But and just the other thing, just to want to talk to you about in the origin of Barrett's esophagus, is the other question we're interested in is Barrett's always the precursor for this cancer? Because here, you can appreciate this cancer here. This is the non-cancerous Barrett's nearby. But you can't always see that when you diagnose the tumour. Often the tumour may be quite big, so the question arises, has the cancer necessarily come from the Barrett's, or is it just that, and you can't see it, or is it actually not the necessary precursor? It can occur in some patients, perhaps straight from this gastric junction. So that's the other question we wanted to address, because obviously if not all cancers come from the Barrett's, then if we screen and look for the Barrett's, that may not always be the source. So we may not be able to improve outcomes for those patients. So new sequencing technologies have really enabled us to have a new window into this question, because it's enabled us to do some sort of archaeology and trace the ancestry of these cells, even if we can't see it develop. And we've been able to do that by sequencing individual cells, so going down to a single cell resolution, to look at the mutations in the tissue as well as the genes expressed, and to look at the mutations in mitochondria as well to understand which tissue they arose from. And I think in biology, the simplest answer is often the true one. And it looks to us from our research that the Barrett's actually comes from those normal gastric cells right at the junction, and that they're reprogrammed molecularly by these transcription factors to turn into the Barrett cells. And that presumably is brought about because of damage from the acid and the bile. It also seems to us, by comparing a large number of esophageal cancers at the single cell level with the Barrett's and the normal gastric tissue, that all esophageal cancer probably does arise from Barrett's, even if you can't see it. So that would therefore mean that it really might be important to try and come up with a screening test for Barrett's esophagus, because if we could do that, then we'd have a good chance of really preventing esophageal cancer. So, on to the more practical bit of the talk. So what is the usual test for Barrett's esophagus? Well, it's endoscopy, which is a pretty straightforward test, gold standard, routine in the NHS. Nevertheless, the main risk factor, as I mentioned, is heartburn. And I'm sure many of you have experienced heartburn. And you can imagine that if we were going to try and endoscope everybody with a little bit of heartburn, that would probably be rather unfeasible. So when I started thinking about this, which was quite a long time ago, about 20 years ago, when I was actually walking from, I was doing a clinical attachment at Queen's Hospital in Romford, and I spent a lot of time taking samples from patients and taking them to the lab, which was based at the London Hospital. And so I was often walking with my Dewar flask full of biopsies on the tube. I don't think I'd be allowed to do that anymore, but that was the case then. And really thinking to myself, there must be a better way to sample the esophagus, both for research purposes, but also to benefit from patients, the majority of whom don't even know they have Barrett's or not. So how could we do it without an endoscopy? And so the idea was to think about a much simpler technology, something that could be done in the GP surgery or an office setting, something that could be obviously accurate enough but easy to scale, acceptable to patients, affordable, and easily accessible. So you might say, well, what about blood tests? So back when I was first thinking about this, we certainly didn't have the fantastic advances being made now in blood tests for esophageal cancer, and I'm sure you'll be familiar with the new big GRAIL trial being launched in the NHS with their Gallery blood test to look for cancer through DNA shed into the blood. And this technology, the sensitivity is improving all the time, and the idea is that from this blood sample you can detect multiple cancer types from the same blood sample by looking at mutations in the DNA with some technologies, or other alterations around the DNA like methylation changes with the GRAIL technology to find cancer. If we look at the stage of the cancer detected, where stage 1 is very early disease and stage 4 is advanced, it's not surprising, but it's going to be much more likely that you'll detect the advanced cancers than the early cancers. Now, what we're interested in Barrett's is detecting pre-cancer, so pre-stage 1. And you'll see that with the current technology, the sensitivity falls off very dramatically to around less than 25% for stage 1 disease. So I think it is very promising, but at the moment, for the kind of early that I'm interested in, it's not sensitive enough. So the approach that we have been considering is whether we could first of all, find the individuals at risk in the population. So heartburn is a key risk factor, but there are others we might add to that to decide who to test. And then to have a very simple office-based test, something that doesn't rely on endoscopy, as a triage to then decide who needs an endoscopy. It's likely that you'll still need the endoscopy to confirm the diagnosis, but also because our treatments are delivered down the endoscope. So not only can you confirm the diagnosis, but you can potentially deliver the treatment at the same time. So just a word about who to test. So the main risk factors for this disease, both the Barrett's and the cancer, are male, Caucasian, greater than 50 years, being overweight, smoking, and importantly, having acid and bile reflux and heartburn symptoms. And not surprisingly, if you have more than one risk factor, your chances of having Barrett's esophagus go up substantially. So if you've got reflux disease and one of these risk factors, then the prevalence of the disease is around 12%. So in all the studies that we've done, we've used medication for heartburn as a key identifier of people we should test. And the good thing about that is you can search GP records, prescribing databases, to find who's on these medications. And for any screening program, it's very important that you have an easy way of identifying the people at risk. You can't just rely on people to come and find you. You need to be proactive. So this is the test that we have developed. So it took a while to kind of iterate on this. The first device that I made in the engineering workshop at the LMB, in fact, was a sort of bottle brush type of device. It looked like a bit of a sword swallowing effort. I never actually swallowed it. But the idea was to just find an easy way of collecting cells, first of all, and then to develop a lab test that would identify the cells we're interested in. But this gradually evolved to a capsule containing a compressed sponge. So here's our gold standard endoscopy, where you rely on the image to identify the lesion, the Barrett's, and then take pinch biopsies guided by the image. Usually done in a hospital setting, requires 3 professionals, the endoscopist delivering the endoscope, someone looking after the airway, and someone to help pass through the endoscopy forceps. The test that we've devised is very, very simple, embarrassingly simple really, but that's the whole point, that can be done sitting in a GP surgery, administered by one person, and a nurse has delivered this test for most of our studies. So you swallow the capsule tethered to the thread with some water, and it will just travel down the esophagus by peristalsis. As it reaches and sits in the top of the stomach, the capsule will dissolve and out will pop this mesh sponge. That can then be pulled back over a few seconds to collect the cells. So this is just a cartoon to show you how it works. Hopefully. So here's the capsule traveling down the esophagus. And when it sits in that moist, warm environment, the capsule will dissolve. It was just gelatin, but now it's vegetarian, so it takes a couple of minutes longer in the vegetarian form to dissolve. Out pops the sponge, which is a medical grade foam, and it's a little bit abrasive. Some people said it's a bit like a Brillo pad, and that will collect the cells as it's pulled up. You collect 1 million plus cells on this sponge, both sort of on the surface and trapped within it. So it's a really very rich sample. I don't know what you think about the idea, but patients find it really very acceptable. The whole test takes 10 minutes. It's just a few seconds to pull it out, and that's the bit that's going to make your eyes water a little bit. I always have one spare in my bag if you want to try it later. So yeah, pinch biopsy down the endoscope, or this kind of cell sample from the Cytosponge. Now, you'll immediately see that you sort of lose the spatial orientation a bit, because these cells are kind of, they come off in clumps, and they're mixed together randomly with the normal cells, these big flat ones down here, and the cells you're interested in. So the important other aspect of this test is what you do with the cell sample. So the other important thing we had to consider is how you would get the cells off and how you would transport them to the lab, because that needs to be scalable and easy. So you just put that sponge into a simple preservative pot that contains an absolutely standard preservative and send it off to the lab, where we get the cells off and spin them down. But this just gives an idea of the different types of cells that you will find in the sample. So you find some gastric cells from the top of the stomach. They're a really useful quality control, because if the capsule hasn't reached all the way into the stomach, then it may not have reached the distal esophagus either, which is where the Barrett's is. So we look for the gastric cells as a quality control measure, and that's part of our readout from the pathology lab. If we don't see gastric cells present, then we actually ask the patient to repeat the test, because we can't exclude Barrett's for sure. This is the appearance of the Barrett cells, and then this is the normal, healthy squamous epithelium. Now, you can spot these Barrett cells, and I just pointed them out to you, but this is really quite a big sample, and so to make it much more objective, we wanted to define a marker that would highlight the Barrett cells of interest. So to cut a long story short, this was an experiment where we did a sort of hypothesis-generating experiment just to find differentially expressed proteins between the top of the stomach, the Barrett's tissue, and the normal squamous tissue. So we identified a long list of differentially expressed proteins. We narrowed those down. We then looked for antibodies where they existed or generated an antibody in this case to be able to develop an immunohistochemical assay that would nicely highlight the cells of interest. And the TREFL factor 3 antibody performed very well in our hands. There are other candidates we could have chosen, but this is the one we decided to stick with for our laboratory test. So this is to give you an idea of the size of this sample with the pathologist screening it for the Barrett cells. And you can see how big it is, much bigger than a pinch biopsy, and therefore a little bit time-consuming to screen. So this is where the immunohistochemical test really comes to the fore, because it really helps them immediately spot the cells of interest and cut down the time taken. And furthermore, this immunohistochemical test is very well suited for machine learning types of techniques. So the machine learning can do several things for us. It can help with the quality control step, so that we've trained the algorithm so it can identify whether there are gastric cells or not. It can also identify these goblet cells stained with TFF3, so these brown patches, and highlight those so that it can eventually give you a confidence estimation of whether it passes quality control, yes or no, and whether it's likely to have Barrett's esophagus or not. The high confidence samples can effectively be signed off almost immediately by the pathologist, and the ones which have lower confidence would then still go through the manual review. Now, you might say, why can't it be completely automated? Well, potentially it could be, but the regulation actually around artificial intelligence algorithms for use, for clinical use in digital pathology are rightly very stringent. So we've currently developed this to be a triage tool to assist the pathologist rather than to replace the pathologist. The other thing we find with these kind of specimens is the pathologist adds a huge amount of value because they may spot other things in the sample. So there are other diseases you get in the esophagus that they can also spot from the sample that we obtain. So what does the evidence look like so far for this test? So the first trial that we did was really a feasibility trial, because you can devise the best kind of diagnostic test you like, but if patients find it really unacceptable, then you're not going to get anywhere. So the first thing was just to say, will people come and have this test? Can we do it in a GP surgery? And to get an idea of accuracy. And that was encouraging. So then we went on to do a study properly powered for accuracy, which was a case control study. So we identified people who we knew had Barrett's, who were having regular checkups, and asked them to swallow the cytosponge before their endoscopy, and compared that to individuals with reflux without Barrett's, so that we could really identify the accuracy of the test. And that looked good. So then we proceeded to a randomized trial in the screening primary care setting to really ask the question, do you identify more Barrett's esophagus with this test than you do with usual care? Usual care in this case means the GP doing what they ordinarily do, which is to prescribe the medication for the reflux and to refer for an endoscopy just if they're concerned and they feel it's necessary. So under the NICE guidelines that we work to, GPs don't refer patients with heartburn for endoscopy unless they're really concerned there could be something else going on. So this was a huge study across England. More than 13,000 patients were randomized into two groups, half for standard of care and half in the Cytosponge. And these were all individuals that we knew were on medication for their heartburn that we got from searching the GP records. And the question we're interested in is, do you diagnose more Barrett's esophagus using the Cytosponge than standard of care? So this was conducted in such a way that it was as we would do it in routine clinical practice, with the idea being that if it was successful, we could start to think about implementation. So the result was reported to the GP, an average of 17 days. The GP would contact the patient with the results, and we didn't endoscope all of the patients in this trial, just those with a positive Cytosponge result was referred for endoscopy within 6 weeks. So, what did we find? 39% of patients were interested to take part. So this was a letter out the blue saying, would you like to take part in a research study? Came from your GP. So, getting patients to take part in research, a lot of people don't have time, aren't interested. So we thought that was pretty reasonable. Then there's a bit of a drop-off because people are on anticoagulants or medication that meant they weren't fit, for example, or we couldn't give them an appointment that was convenient for them. So in the end, 24% took part in the Cytosponge. We analysed the data for the whole of the group that were offered the Cytosponge, even if they don't take it up. The safety was excellent, and people find it really remarkably acceptable, so we asked them to score it between 1 being absolutely horrible and unpleasant and 10 being quite enjoyable. You'll be surprised that the odd person said it was quite enjoyable. So this is what the results showed. So number of Barrett's esophagus diagnosed in the usual care compared to the Cytosponge. I was blinded to the results till right till the end, and they asked me what I thought the ratio was going to be. I said I was hoping for it to be 3 to 1. So we were very happy with this result. So tenfold increase in intention to treat analysis. And what was encouraging was that included some patients with early cancer. So if we break this down, the numbers get small here because the main outcome was to look for Barrett's. It wasn't powered to detect early cancers, but nevertheless we found some. So these are the patients that actually swallowed the Cytosponge. And you can see that as well as the Barrett's, we detected a small number of cases with dysplasia and early cancer. So they all went on to have curative treatment. These are the patients who were offered the Cytosponge that didn't take up the offer. So that included 1 patient with an early cancer and 2 with a late cancer. This patient, interestingly, phoned us up and said they were interested in the Cytosponge, but our nurses were a bit worried and referred them on for an endoscopy straight away. This is the usual care arm, and you'll see that the cancers detected were all at an advanced stage. So when we got that result, we were keen to actually extend the trial further and see if we could show a difference in mortality, a benefit from being offered the Cytosponge. Because from the National Screening Committee perspective, to really roll this out as a screening program, they would want to see evidence not only that we detected more Barrett's, but it would actually lead to an improvement in mortality. But just as we were getting ready to do that and discuss it with CRUK, COVID hit. But before I tell you about that, let me just quickly give you this little anecdote of this retired scientist in Cambridge who was curious about Cytosponge. She'd had heartburn for 20 years, but she said to me afterwards she thought she'd be a useful control. But lo and behold, she had a positive Cytosponge result. And when we endoscoped her, she had a very nasty ulcer in her Barrett's esophagus, which turned out to be an early cancer. We did an ultrasound, which we do down the esophagus, which confirmed it was early stage. And she had endoscopic surgery as an outpatient to remove the area. And the pathology showed that she had a superficial cancer. So she had a very lucky escape. It was a very, I met her in the clinic to tell her the results, and it was a very moving moment, really. So then we were thinking about whether we should do a mortality trial, because that is the gold standard. So this just gives you some idea for different cancers, stomach, cervix, and colorectal, looking at the impact of screening. So stomach cancer is interesting because the incidence and mortality has been decreasing steadily in the past, several decades. There's been no screening, but we know the main cause for stomach cancer. It's an infection with Helicobacter pylori, and we've been eradicating that bacteria. Cervical cancer is a screening success story, and now, of course, we have a vaccine. But there's been continuous screening throughout this period and a reduction in incidence and mortality. Colorectal cancer was introduced during this period, and then when you introduce a screening test, what you see is an increase in incidence when you start detecting more cases. But if you're doing good through your test, then you'll actually then start to see a reduction in mortality and a reduction in incidence. So the question is, could we show that with Cytosponge, and would that be a necessary next step? Some people go one step further and say you shouldn't just show a reduction in deaths from your cancer of interest, so colon cancer in this colon cancer study, but also you should look at overall mortality, because if you don't reduce overall mortality, maybe that also means that it's not necessarily having an impact overall on the population. So you can see that the barriers to introduce a new screening test are very high. And this is an ovary cancer trial which is just reported, which unfortunately in the end didn't show any reduction in mortality from ovary cancer screening using a blood test, CA125. So we were just getting ready to do that, and then COVID hit. And this is what happened to various diagnostic tests during the first lockdown. So CT and MRI scanning, and then the endoscopies, colonoscopy, gastroscopy, and you can see that the numbers absolutely plummeted because there wasn't space in the diagnostic services, and gastroscopy in particular was a real concern because it's an aerosol generating procedure. So when you compare, this is our endoscopy room in COVID with everyone dressed up. And this is comparing someone in their PPE for administering a Cytosponge test, but much, much more simple. Can be done in the office setting. Doesn't require as many personnel, much less aerosol generating, just a few seconds when you withdraw it. And I had a call from a surgeon I knew who was working for NHS Scotland to help with their COVID recovery back in August of 2020, and he said, Rebecca, we've really got a big problem with our endoscopy bottleneck in Scotland, and I remembered Cytosponge and just wondered if it could help. Now, all the work we've done to date that I've just shown you was in screening, not for people with symptoms, which is a related problem, but not an exactly the same problem. So if a patient's been referred for an endoscopy to the hospital, then that's because the GP is more concerned. We're not doing a proactive screen. But nevertheless, given the situation, I thought we should at least turn our attention to try and using Cytosponge in that context. So primary care was now off the cards. Screening didn't seem to be appropriate during COVID-19, but maybe helping with the COVID-19 backlog for patients with heartburn symptoms in secondary care would be appropriate. The other big backlog that they've had during COVID and continue to have is people with Barrett's undergoing monitoring. Because once you're diagnosed with the condition, then you keep coming back for repeated endoscopy to try and find you at that point you're developing cancer to give you some treatment. So we had to think of other ways that we could identify not just the Barrett's, but the Barrett's that's going bad or turning to cancer. And for this, we can use other morphological criteria within the specimen that the pathologist grade as dysplasia, but also another immunohistochemical marker for the very well-known cancer gene, often called the guardian of the genome, called P53. We're doing a lot of research in the lab to find other ways of adding to these biomarkers, looking at DNA copy number changes. But in the middle of a COVID pandemic, when you need to roll out a test pretty fast, that wasn't really an option. So we had to rely on these. So just before this time, we had set up a laboratory to perform the Cytosponge processing and reporting to a clinical standard. So we'd already licensed the device to Medtronic. It was being made as a CE marked device. But as a devices company, they couldn't provide the laboratory testing. So we decided eventually to set up the lab ourselves. So we had to move pretty quickly to a kind of high throughput methodology and to be able to report at scale. And this just shows you the process it goes through, where the cells are washed off, pelleted down, and then cut into these sections, and the immunohistochemical staining performed. The other thing is, how do you train people to administer this test? It's a pretty easy test, but still, you can't do it to yourself. So we had to send our nurses up to Scotland, first of all, to train all the health boards in Scotland as to how to administer the test. And this is my nurse, Irene, that developed a training program and rolled it out at very quick speed. And so since the beginning of the pandemic, we've now rolled this out across NHS Scotland, who've done over 2,000 tests to date. NHS England then followed suit. And both Scotland and England have been using it for symptomatic patients with reflux in secondary care and the Barrett's monitoring. And then more recently, we were keen to get back to our screening, our original proposal for this device. And so we, thanks to this charity, we set up a mobile unit for screening. And you may have seen it because it's parked outside Shelford Surgery, because it wasn't really appropriate to go into GP surgeries during the pandemic. So just to finish off with, just to tell you what we've been doing for the Barrett's monitoring, because it's a little bit different from finding the Barrett's. So for Barrett's monitoring or surveillance, they have the Cytosponge test, and we look at the biomarkers to see, it should have the TFF3 because we know they've got Barrett's, and then we also look for atypia and this P53 overexpression. And if those are present, one or both, they get an endoscopy. If it's negative, then we do look at the clinical factors, particularly how long the segment is. That's what this means. It's 10 centimeters or long maximal, or 6 centimeters or long circumferential, and the age and the sex of the patient. If clinically they're at moderate risk, then we do more frequent cytosponge or alternate with endoscopy. And if they're low risk on both of these parameters, then we've been using cytosponge instead of the endoscopy for their monitoring. So this potentially can really reduce the endoscopy bottlenecks in our gastroenterology services. And how well does this perform? We have to compare with our gold standard endoscopy. So these are patients with Barrett surveillance monitoring undergoing cytosponge that looks as if it's high risk, that then go on to have an endoscopy. And you can see the proportion here that have early cancers diagnosed on their endoscopy in red and yellow. The clinical risk factors are kind of a safety net to help us rescue any with a bit of dysplasia that we may have missed from the cytosponge. And then the low risk really have a very low risk, less than 2%. They continue to have cytosponge monitoring. And we've been rolling this out in East Anglia currently. This is just where we got to a few months ago, 200 odd patients where we were using this decision tree. And just to give you an idea of how the proportion of patients break down into the different groups, about 17% then go on and have an endoscopy, and the rest can be monitored. And these are just to give you an example of the sorts of patients. So this is a man aged 58, I can't quite see it from here, who's a non-smoker with a fairly long segment of Barrett's, who we found cell abnormalities, the brown staining of the P53, had an early cancer diagnosed, but actually the endoscopist couldn't see it. But they knew it must be there from our cytosponge. They took lots of biopsies, found it, and resected it. Now this is a patient 57 with a shorter segment of Barrett's, also rather abnormal looking cells with the P53 overexpression, but the endoscopist really couldn't find it, and the endoscopy and the biopsies look fine. But we're quite concerned with that kind of appearance and suggest that they keep a close eye endoscopically. And that just goes to show, with any of this sort of research, when you're looking at a diagnostic, the gold standard isn't always gold. And this is a female patient with a short little segment of Barrett's, the kind of patient we would think is rather low risk, but again had abnormalities and had an early cancer detected. So these are the kind of patients that we're finding and bringing through, and we continue to evaluate this data and audit it in real time. So, you know, where are we on this innovation cycle? I guess we're still testing and in revision, starting to implement, thinking about how we can scale it up to make it really available within the NHS. But we kind of interrupted our research because we were thinking about the National Screening Committee wanted us to do a big randomized controlled trial powered for mortality. Now we've been doing this implementation. So one of the questions is, you know, do we keep going with our implementation and spread, or should we also go back and do a much bigger randomized controlled trial in the screening setting? So it's something we could discuss. We've put in a proposal to CRUK and NIHR to do this big screening trial. We have funding. In the meantime, there's quite a lot of implementation going on. A screening trial powered for mortality will require about 120,000 patients to be randomized, follow up for 7 years to 12 years potentially to get the full result. Quite expensive as well. So it's really interesting to think about, you know, at what point something's ready to really be implemented, or to what extent you should really continue to do randomized controlled trials. And that's a big topic of debate at the moment in the kind of screening diagnostic community. So that's pretty much all I wanted to say, just to give you an idea of how long we've been working on this. A long time. We have done other things as well. I've not been doing this completely full time. You know, like as with any of these things, you learn a lot as you go along. There have been ups and downs. We've had the generating the data and the randomized controlled trial evidence. Also a lot of other studies in parallel looking at health economics, which I haven't talked about, quality of life acceptability studies, working with colleagues. And then the whole commercialization question, which has been quite an interesting journey, because we had to decide on whether to do a startup initially, and then the MRC were very keen that we licensed the technology rather than a spin-out. But finding a good license partnership was complex, because this is both a device and an assay. So we licensed it at Medtronic, and now we ended up then later on setting up a company to do the lab processing, because it was clear that a devices company couldn't really deliver on the lab. So I hope I've convinced you that esophageal cancer is a good example of using knowledge of disease pathogenesis to then develop a new paradigm for early detection. We've got some way along this cycle of innovation and commercialization towards adoption and scale up, but we're now thinking about this screening trial powered for mortality to see if this would be really suitable for screening as well as diagnostic testing in patients with symptoms and monitoring. But whatever we do, I hope we continue to obviously learn the lessons we can via our implementation programs to really continue to evolve and improve the testing that we're doing. So this is the team on a recent sponsored walk, now that we could all get together again in person. And I'd like to thank the funders very much who've made all this work possible. And thank you very much.
Well, Professor Fitzgerald, that was absolutely riveting. Thank you. You could hear a pin drop in the room. Wonderful example of going all the way from the science to something very practical. We're open for questions in the room, and also if you're out in the ether somewhere and you'd like to do a Q&A, I'll be able to see it on the screen. But you can't see that I'm holding it up, can you? But anyway, from the floor, please. Yes, gentleman back there.
Hi, thank you very much. Question, if you diagnose Barrett's in the first place using the sponge, and so you don't know how large the segment actually is, how does that influence the monitoring of the section where you said the low and moderate risk?
Yeah, so at the moment we always use it as a triage to endoscopy, so they would get a baseline endoscopy where we would make that assessment as well as any dysplasia, confirm it, and then carry on. But the other thing that we're learning is that actually the amount of TFF3 positive groups you have gives you a pretty good estimation of the length. And you know, we're applying machine learning algorithms anyway to identify these clumps, so it can also quantify the lumps of TFF3 positive cells and give you an estimate. Potentially it can also look at the spatial distribution and other things as well, which may add additional information. So potentially you could get, you know, even more information from that initial screen and maybe then put people into those groups. But I think it would be quite a big leap to go from Cytosponge to diagnose Barrett's to then go straight into a kind of Cytosponge monitoring with no endoscopy at all. I think it would take the endoscopy professional community and the gastroenterologists, you know, they would find that, I think, quite a bold move. So I think for now that kind of confirmation with the gold standard would probably be required.
I have a question now from John Scott out in the ether, who says, how are you currently manufacturing the Cytosponge?
How are we manufacturing it? So it's a CE mark device from Medtronic. You may find this curious. So for all of our trials, it was made by a local manufacturing company that I identified in Essex, who make a lot of low-cost diagnostic devices, including spacers for inhalers and things like that, called Europlats. And so they made all the devices for our trials. But now, for the CE mark device, that's made by Medtronic, but they actually use a sub-assembly from Europlats. It gets shipped to California to be encapsulated and packaged, and then back via Holland to the UK. It may take a while to simplify those processes, apparently, for the manufacturing regulatory approvals and so on that Medtronic have to work to, but I hope we can streamline that a bit, especially to reduce some of the air miles and the costs.
Probably pretty light, though.
Does the way you withdraw the sponge make a big difference to the assay and the amount of material you get? Is that a difficult factor or not important?
Actually, withdrawing it doesn't seem to be very important, but how you swallow it probably is important. So you need to, so the way the esophagus peristalses, if you take little sips, it will stop and even go into a little bit of spasm. If you take one big gulp, then it'll tend to go all the way down. So we noticed there was quite a bit of variation between our nurses administering the test as to the proportion that went all the way down to the stomach, and samples were retrieved with gastric cells. So we then had to do a little bit of trying to figure that out, relying on our physiology, talking to the nurses about their different tips and techniques. And so we now, you know, in our training, very specifically talk about taking big gulps of continuous big gulp of water. The withdrawal is done as quickly as possible, because that's the slightly unpleasant bit. And it doesn't seem to make, as far as I know, it doesn't make any difference. I think the nurses all pull it out pretty fast, and we just get a lot of cells. The diameter of the sponge is pretty much, you know, the esophageal diameter. So
you're better off with beer drinkers than whiskey drinkers, really. Any more questions from the floor?
Boris Johnson had a look at it and said, is it like a chimney sweep then?
Ladies and gentlemen, we have no open
There's
questions.
Another question over
Oh, is that? Oh, John, yes.
You mentioned that it removes about 1 million cells.
At least.
At least, but then later on you said it can be done repeatedly. What kind of interval do you have to leave in order to heal whatever damage it's done?
Well, on the early studies, we endoscope people immediately afterwards, and then you see a very small graze just above the lower esophageal sphincter. It's a very minimal graze compared to the endoscopic biopsies we take. If you take a biopsy and endoscope someone a week later, you won't be able to see your biopsy mark. For the monitoring that we do, we wouldn't do the sponge that frequently for the people with known Barrett's. If they got an inadequate sample and we were doing it again, then, you know, we wouldn't do it the same day, but we'd give them an appointment as convenient, which would probably be a few weeks later. But, I mean, it hasn't really, you know, if you did it the next week, it would be fine, I think.
Thank you.
But we haven't really tested it. And I think most people wouldn't want to do one after the other, or one today and one tomorrow. I've done it a few times myself, I should say, and it's, I mean, like any of these tests, it's not something you're going to rush and want to have done too often. But compared to an endoscopy, which I've performed on many people but wouldn't like to have myself. I think the Cytosponge is really quite tolerable. Well, sticking the thing up your nose isn't very nice, is it? Probably not much different.
So we have got a rush of questions here. Laurie D. Cregar asks, what happens if the string tears? And Fred McKeating asks, has anyone ever bitten through the string? So I thought we might conflate those two together.
I don't think anyone's ever bitten through the string. So yes, people, that is the worry. Could it get detached? So it has got detached, less than 1 in 2,000. In fact, since we started in COVID and done 5,000 odd tests now, we had 1 detachment in Scotland in a training session. If it detaches, it's, so this is sort of, I don't know if this is interesting or not, but the way we cut the sponge, the sponge are huge blocks as big as a room. And the density of the foam varies from the perimeter to the center. And so where you decide to cut your bits of foam will give you the density of the sponge. If it's not dense enough, then when you put your thread through, then it's more likely to tear through the sponge. And if it does detach, that's what's happened. It's just torn through the sponge material. So, it will happen by chance once in a while where you just haven't got many struts, because the knot design is pretty strong. But it's pretty uncommon. It's not a big deal because it's really inconvenient more than anything else, because you're doing it instead of an endoscopy. So all you're going to have to do is do an endoscopy to retrieve it. It's not uncomfortable. You just, the nurse pulls out the thread and there's no sponge. And you're sitting there thinking, oh, it's just like eating something. It's sitting in the stomach. And you just do an endoscopy and remove it. But it doesn't happen very often at all.
Phew. And Tessa Kilvington-Shaw asks, with 120,000 samples to test, would they all be GP records identified, or would you use people who self-diagnose and self-medicate severe indigestion?
Yeah, good question. So currently in our mobile diagnostic unit outside Shelford, we're for the first time looking at people who self-refer, who are self-medicators, to see what the yield of that sort of strategy is. But the way we plan to do it for the Best 4 trial is actually to use the digital prescribing records and send people a text message to see if they're interested. And then only contact those that are interested. It just makes the whole thing a lot more manageable and streamlined. But one could, in a way, it would be very nice to be able to also accommodate people who are self-medicated, because many people with heartburn never even see their GP. But logistically, just gets quite difficult to do. But I think something for the future that should be a consideration, including pharmacies, actually.
Well, that's probably a nice place to end on. There are no more questions. There are no more questions in the room. John, another question? No? Professor Fitzgerald, that was absolutely smashing. Thank you very much.
Pleasure.
Taking us all the way from the idea to the practice and the manufacturing, which is always appealing to me. Thank you very much indeed.